So just to provide an overview of today's webinar, we will be providing the policy and context around the hypertension case finding service. We'll be providing a service overview, and then we'll provide some details around the service description. Then we'll move into how to deliver the service effectively, particularly with an emphasis on how we're going to be working with general practice and the Greater Manchester ICS arrangements. Then we'll talk about the service payments and the claiming process, some next steps and a Q&A at the end. So in terms of policy and context, cardiovascular disease, or CVD, is one of the leading causes of premature death in England. It affects 7 million people and accounts for 1.6 million disability-adjusted life years. Hypertension is the biggest risk factor for CVD and the top 5 risk factors for all premature death and disability in England. There are approximately 5.5 million people that have undiagnosed hypertension in England. It's a key driver of health inequalities and accounts for around 25% of the life expectancy gap. So early detection of hypertension is vital. There's evidence that community pharmacy can provide a key role in detection and treatment of hypertension. Community pharmacy engagement has the potential to improve outcomes and reduce the burden on general practice. And the level of detection are expected to have fallen over the past year due to the impact of COVID-19 on routine blood pressure monitoring. And just to add a bit more context here, there is now Northwest CVD prevention work ongoing because it's recognised that post-pandemic, the level of cardiovascular risk has increased and the number of undiagnosed people is on the increase as well. So there's a huge drive from the ICS systems to try and work together collaboratively, and community pharmacy have a key role in that. Next slide. So why the hypertension case finding service? So the hypertension case finding service will support the work that general practice and wider primary care network teams will be undertaking on CVD prevention and management under changes to the PCN DES, or the Direct Enhanced Service. It is expected that primary care networks will work proactively with community pharmacies to improve access to blood pressure checks via the hypertension case finding service. In 22-23, PCNs must ensure processes are in place to support the exchange of information with community pharmacies, including a process for accepting and documenting referrals between pharmacies and general practice. So in that context, the CPPB working group have been working together with the GM ICS to set up a system which will allow you to work in an integrated way with general practice that Lou will cover a bit later. Next slide. So in terms of the service overview, the hypertension case finding service is nationally commissioned advanced service for community pharmacy, and pharmacies must provide both stages of the service. And I'm going to stop there and emphasize that point. We have had a look at the initial data, and it does appear that the clinic checks are of a higher level at the moment, but it is critical that we provide both stages of the service. So in stage 1, this will involve identifying people at risk of hypertension and offering them the opportunity to have their blood pressure measured, i.e. a clinic check. And at stage 2, this is offered if a person's blood pressure reading is high at stage 1. A person will then be offered 24-hour ambulatory blood pressure monitoring, ABPM, and patients who are then identified with high or very high blood pressure will be referred to their general practice for onward treatment and management. So additionally, at the request of general practice, a community pharmacy can also undertake ad hoc clinic measurements. So this may include individuals already diagnosed with hypertension and ABPM. So in essence, in addition to stage 1 and stage 2, GPs will be able to also ask community pharmacy to provide clinic checks and ABPM as well. So we'll talk about that a little bit later on. Next slide. So in terms of delivering the service, so to date, over 450 pharmacies in GM have already signed up by the NHS BSA to deliver the service, and many pharmacies have already started delivering the service. We know that as of April 22, over 3,000 referrals had been, clinic checks had been completed by pharmacies. So in terms of delivering the service, contractors will need to purchase or rent both meters, blood pressure and ABPM meters for each service stage. Currently, the service can only be provided by a pharmacist, but there are plans to extend to technician, and the date is to be confirmed, and this is expected by the end of this year. When measuring blood pressure, the patient must be able to rest their arm on a table bench at a suitable height, and feet should be flat on the floor. IT equipment must be accessible within the room. Pharmacies can promote the service to the general public and patients, and you can refer to the PSNC marketing materials if you need support with this. Ensure that you provide healthy living advice and make every contact count. So this is a real opportunity for pharmacy to provide leaflets on diet, exercise, weight management, and stop smoking advice. And indeed, many of you may already be providing some of these services in your pharmacy. Patient consent is verbal. Off-site provision can be arranged, but it must be with oversight and agreement from NHS in ENI regional team. And if you need to also, if you do any large off-site events, you need to consider the capacity for ABPM monitoring at these sites. Next slide. So in terms of delivering the service, the patient eligibility, the inclusion criteria is adults which are 40 or over with no diagnosis of hypertension. By exception, any patients under 40 years old with a family history of hypertension can be seen through this service, but this is at the pharmacist's discretion. They could also consider if you are approached or self-requested, i.e. anybody who's 35 to 39 years old that has come to your pharmacy, you may provide it at pharmacist discretion. In terms of exclusion criteria, if the patient is unable to give consent, that is excluded. If a patient is with known AF, that is an exclusion criteria. If they're under 40, it's an exclusion criteria. And people not referred who have their blood pressure already regularly monitored by a healthcare professional. An additional consideration is if you cannot support the patient due to the cuff size, and for general practice sending referrals to community pharmacy, it's important to make sure that adults specified by the general practice are provided a clinic and ambulatory blood pressure check on agreement. And in this case, the patient may already be receiving treatment for hypertension, but general practice have asked for some support. Thanks.
Thanks, Lodger. I think it's over to me now for the next few slides. Thanks. Right, so on to delivering the service and getting prepared and ready. So for those of you that are just getting started with the service, it's important that you prepare well. And this slide sets out some of the information that may help you to get organised. So the first things is getting your pharmacist ready. So please ensure they're familiar with the NICE guidance, and that'll tell them everything they need to know about blood pressure monitoring. Ensure you read the service spec and that you have a copy of that available to you, especially in the early days when you may need to refer to it on a more regular basis. And complete any training requirements by the manufacturer of your equipment. So that could be some written information, or it could be some of the videos that some manufacturers provide as well. And finally, for the pharmacist, there is a PSNC briefing, and we've linked that at the end of the presentation in the resources section. As always, it's important that your pharmacy team are there to help you and support with delivery, so please make sure they are briefed on the service, again using the briefing that we've linked at the end. And that includes your locums and your relief staff, and ensuring that they know what to do if you're not there. So it may be that patients are dropping in or GPs referred them, and they may not be trained to do it. So we need to ensure that patients are booked in with the pharmacist when they get back. Finally, please make sure you've got an SOP in place and ensure that it includes a process for recalibration, maintenance and validation of your equipment. And that may differ from one manufacturer to another, so it does need to be checked and popped into your SOP. PSNC have developed a really handy flowchart for the clinic check, so please have a copy of that laminated and ready in your consultation rooms. And further in the presentation, I'll show you a flowchart that we've developed for general practice as well, and we recommend having that laminated and available to you. So on to the GP referrals. Please familiarise yourself with the PharmOutcomes recording templates that are now on PharmOutcomes. There is a standalone module that I'll talk about in a minute or so. But for the EMIS practices, they've now got a direct referral button. So referrals will arrive into your PharmOutcome Services tab in the same way that they would normally do for things like GPC, PCS and DMS. The referral button on the GP end is in the same place that they'll find the GPC PCS button, just in case any practice asks you about it, because we have had a couple of practice where it's not configured properly and that button wasn't there. So if any practice mentions that they can't find that referral button, just let the LPC know and we'll help to arrange that for the practice. At the moment, for the non-EMIS practices, which I think is about 20% in GM, there's no electronic solution. So general practice will need to make other arrangements to send patients to you. And we're encouraging them to do that using NHS mail, as it's the most secure method of transferring information. There is a module there on PharmOutcomes, like I just mentioned before, that you can use for manual entry, and this will send information back to all practices. So please do use this for any referrals from GPs that come to you via other routes, and also for any case finding and ABPMs that you do in your pharmacy. It is really important that you work with your local practices to agree a process, especially if your practice is not going to be using EMIS, because they may want to do things in a slightly different way. And that conversation should include the capacity that your pharmacy's got to accept referrals for both the blood pressure checks and for ABPM. It would also be useful for you to discuss the types of patients they may want to send across to you. Some of the typical examples that we're starting to see are things like contraception and HRT checks, and anybody with a QOF indicator of a blood pressure check being needed. Part of our comms to general practice has included the importance of these conversations, and it should always be two-way. So if they've not already been in touch with you, please do get in touch with them, and hopefully they'll be expecting a call from you. What we don't want to happen is for GPs to send more referrals to you than your pharmacy can manage, and for this to cause some problems at a local level. The important thing is the person, is the patient, and it's always the patient, and ensuring that they get the treatment that they need. A couple of last points about PharmOutcomes. Firstly, we haven't got a demo video, unfortunately, available for you, but we will, when that becomes available shortly, we will make that available and send it on to you. The GPs, however, do have an EMIS video that they can watch, and we have sent that out as well. A couple of other bits is the when you record on PharmOutcomes templates, you don't need to collate the weekly data on the collation form and send that in manually to GPs, because PharmOutcomes will send a referral across to the GP once you press save. And also, please ensure that your practices are sending referrals on the correct PharmOutcomes templates. They will have a choice now of 3 different templates, one for ABPM, one for clinic check, and one for GPC PCS. And we have seen a couple of practices accidentally send those referrals on the wrong template. So if they do that, please reject it and give them a call and just let them know to resend on the correct template. If it does become a problem for you with any of your GPs, again, please let the LPC know, and we'll be happy to have a chat with the practice manager and sort it out for you. So on to working with general practice, just a summary of what we want you to do on this slide here. Please inform your GPs that you started delivering the service and that you're going to be sending results over to them via PharmOutcomes. Please share the GM referral process that I'll show you on the next slide. You should hopefully have already received this, but if you're having a conversation, it's good to reinforce that process with them. Agree how the practice is going to work with you, and if there's any particular patient groups that they would like to prioritise, and ask how you can help with it. We have done a lot of work, like Lovejeet said, a GM system level to engage the GM system and the GPs and the PCNs, but your input really is going to be vital to the success of this service, especially around that referral pathway from general practice. This next slide here, it does look a little bit complex, but it is really quite simple when you sit back and have a proper look at it. I'm not going to cover it in too much detail. You can take it away and you can have a look in your own time. We'll send a copy of the slides out to you afterwards. But what it does is it summarises the process for general practice referrals and the pathway that patients will take depending on the results. So please do have a look at it and share it with your local GPs. So the last few slides before we start getting into the Q&A. Hopefully you've seen the information around the payments and setup fees, but just to recap it for you, when you register for the service, you will receive a setup fee of £440, and that's a contribution towards the cost of delivering the service. The fees thereafter are £15 for each clinic check and £45 for each ABPM. But there are some incentive payments built in as well. So if you registered last year and you did 5 ABPMs, then you'll have received your £1,000 incentive payment for the first year. Then there's a target of 15 ABPMs this year to receive a further £400 and 20 next year for a further £400 again. So that's up to £1,800 worth of incentive payments. If you missed registering last year though, or you didn't complete your 5 ABPMs, you can still receive that £1,000 incentive payment for this year if you meet this year's ABPM target of £15. And similarly, if you miss this year and you only manage to do it next year and you meet that target of 20 ABPMs, then again, you can get that £1,000 incentive payment. So there are still opportunities to get that. The good news is the incentive payment is funded from outside of our global sum, so it is new money for community pharmacy, and it's seen to be a contribution, a bigger contribution to purchasing some of the equipment that you need to do for the service. Claiming payment, this is probably one of the most important slides, and I really want to get the message across on this one. It is really, really important that you know that the PharmOutcomes at the moment does not integrate with NYS. I understand how frustrating that is. I understand that the manual process of doing it is really time consuming, and that our end of month processes seem to be getting longer and longer each month. But for now, you will need to manually transfer any blood pressure checks that you've done to NYS every month. Our understanding is that the NHS BSA is working with Pinnacle on an integrated solution, but we've got no date at this time as to when that's going to be available. And they are working on a couple of integrations, so they're also working on DMS and I think the smoking service, the advanced service as well. So hopefully at some point we'll come to you with some good news around all of that. But for now, please make sure that you transfer everything over manually. Needs to be done by the 5th of the month following the completion, and the NHS BSA will not pay for any late claims. They won't be processed. So please make sure that you build that into your month-end process. So on to the final slide before we start the Q&A. This is the key next steps for you, and it's a little bit of a recap, I suppose, of some of the things we've already told you tonight. So please, like we said, read the service spec, use the hypertension case finding implementation checklist from PCNs that covers all of the actions that you need to do to be able to successfully deliver the service. The checklist, again, is linked in the resources at the end. Please make sure your pharmacy team is well briefed and locums and promote the service using the PCNs resources. Your pharmacy team is really, really key to this service. They need to know what's happening, especially if patients are going to be walking in having been referred by a GP. Finally, speak to your practices, share the GP resources with them, and agree how they're going to send those referrals. Again, make sure they understand the capacity that you've got to deliver the service. And if at any point you feel that you're being overwhelmed with too many referrals that you're unable to cope with, please do talk to your practice managers first. But if you're struggling at all with that conversation, get in touch with the LPCs and we will be happy to help with those conversations. And I think that now is on to the Q&A. So I will unshare my screen so we can talk to you and answer any questions that you might have.
I just had a couple of points to add, Lou, if I may. With regards to the sorry. Oh, thank you. Sorry, I'm not sure what that was. With regards to the GP community pharmacy interface, it's really important to recognise the fact that both community pharmacy and general practice are under a considerable amount of pressure. And in order to counteract that capacity issue, what we've designed, haven't we, Lou, with the GMICS is a process whereby every community pharmacist will speak to their local general practice first. So what you need to do is speak to them and explain when you're ready and you think you've got the capacity to take referrals, you will go and speak to the practice and say, I'm ready to do this. Would you like to work with us? And for that, we've provided a toolkit, haven't we, Lou? Which you can use basically to present to the practice to make it easier for you. And of course, if you need support from us, we can come. And once basically the practice then agree that, and you want to make sure that you agree the numbers in advance so that, you don't have an issue where, you've got 300 referrals and you can't manage it. So that local conversation is really important. And we want community pharmacy to be the driver for that conversation and make sure that they're ready to receive those referrals. So making sure that you have that conversation with your practice when you're ready is really, really important so that the workload and capacity issues can be managed. If general practice do get in touch with you and offer you that opportunity, then please ensure that you absolutely are able to do this and you're able to support it. Because achieving the CVD prevention outcomes especially with the current health inequalities and the current issues that we're facing in terms of risk from cardiovascular disease in the coming years, is very, very high. So I think we have a really critical role to be able to support that. And I know you guys are all doing really well already. So well done to everybody that has actually got through all the training and registered on MYS. Thanks, Lou.
Brilliant. So I think we're on to the Q&A now. We've not got anything in the chat, I don't think, at the moment, but if you've got anything you want to type into chat, please do so. But don't be shy. If you've got a question that you want to ask any of us, pop your hands up and we'll be happy to help. Alison, got one from you there. If you just need to take yourself off mute and we can answer a question for you.
Hi, Lou. I've done a couple of clinics and ABPMs, but I'm finding that PharmOutcomes isn't sending reports over to GPs and I'm having to do them manually.
Right, okay. So what we've done is we've tried our best to get all GPs to provide the email address that they want the referral sending to. It could well be that you've got a practice that you use regularly that hasn't provided the email address to us. If you can put the name of your local GPs into the chat, we can check that for you, and maybe get in touch and check it with the practice manager. So just pop the names into chat and I'll pick that up outside of the meeting if that's okay.
Okay, lovely, thanks.
Brilliant. So have you got any more questions?
Yeah, we have another hand up from Sham.
Oh, got Sham. Yeah, Sham.
Yeah, hi, good evening, everybody. Just in terms of sort of taking this forward with the practices, obviously practices are very busy, and it's very difficult to get in and see the key people. Who would you suggest we should be aiming this at in the first instance? Because it's very unlikely that we're going to be able to get in and sort of discuss this with the GPs in every case. Would you say it's sort of pitched at the practice manager level, or should we be insisting on sort of speaking to the lead GPs, or what's the sort of kind of general sense?
The general sense is that I think the practice manager would be the best first port of call rather than the GPs themselves. And just some assurance for you, Sham, in addition to all the work we've done, we've actually been engaging with the ICS system. So many of our GP board colleagues and the primary care board, the primary care clinical cell, it's been to the clinical senate as well, hasn't it? So many colleagues across Greater Manchester have actually supported and agreed this process before it's come out. So there's been extensive consultation already. We've also been out, haven't we, Lou, to the primary care network leads, PCN CDs. I did an update to them just last week, probably over 80 of them. So they're kind of aware of this. So you should, in theory, be not knocking on a closed door. And what we've said to them is, please be willing to receive community pharmacy conversations. And if you do struggle by any chance, then just get in touch with the LPC and we will support that conversation if you want to take it forward.
Thank you.
Any more hands up? So I'm just popping a message into chat there. Have a look. We've got any more hands up? Not at the moment. Anybody else got any questions? Please put your hand up. There is one thing I wanted to actually just mention, because I got a query from a pharmacy last week, and we've got a response back today actually from PSNC, and it's around claiming for the service. This is around ABPM, and we know that not every patient will want ABPM. We also know that some patients can't tolerate it, so they put it on, they've got it on for half an hour and they come back to the pharmacy because they just can't stand it any longer and they want it taken off. But obviously you've done, at that point, you've done all of the work. You set it up, you've spoken to them, you've attached the equipment, etc. And the service spec does say that you can be paid for that. But then there was no opportunity on MYS. There's no one MYS that you can put it in, is what I've been told. So PSNC have been working with the BSA on this week. And what they said to do is that when you fill in the ABPM part, if a patient has started an ABPM but has not completed it, if you put 1 into both the boxes for the systolic and diastolic blood pressures, NHS BSA will know that you've started it but not completed it, and that should trigger your payment for that ABPM. So just a little bit of extra information there that we got today. I believe PSNC are going to update their FAQ in the next week or so with that information, but just for anybody who it might be affecting at the moment, because I do know I've had some pharmacists contact me about it.
Yeah, and just one more point, Lou, not on that. That's really helpful. I wasn't aware of that myself, so that's very useful. Thank you. Is around ensuring that, you know, when we do make referrals back to general practice, that both stages of, you know, the service are completed. So you do the clinic check, and then the ABPM's the next stage. And then if that basically falls into the risk category, which implies that the patient has high blood pressure, then it would be referred. It's very, very important we do this, because we've had a lot of queries from general practice about the potential numbers of patients that could potentially be referred. But looking at the pilot numbers, the overall numbers are not that high, but it's very, very important that pharmacy ensure that they support the patient. If it's a referral that's required, you know, an appointment's required within 3 weeks because it's non-urgent, but also if it's an urgent referral, please make sure that the pharmacy is actually contacting the practice themselves alongside sending the information through PharmOutcomes. There's a comment in the chat at the moment. As the briefing has now been shared with practices, ICS locality teams are now being approached by practices for a list of pharmacies who are participating within their PCNs. Is there a way of finding out which pharmacies are actively providing service to save the practice? That's from Zoe. Thanks, Zoe, for joining. Nice to see you here. I was thinking to myself, it's not usually a question that comes from the pharmacies. So we do understand that PSNC have just announced that the Shape Atlas tool is now live. Lou, is that right? You know, the tool, and that is going to help any localities or any PCNs or anybody in the system for that matter to be able to locate exactly where community pharmacy are providing the service. So I believe that there has been a PSNC update, and there will be a couple of webinars in the next couple of weeks on how to use the Shape Atlas tool, so we can provide more information about that. I'm also speaking, myself and Lou are also working in the advanced services oversight group with the GM primary care team alongside Alison, and we have actually recently had a meeting about the data, and we have asked NHS England if there is a way that that data can be shared with localities and meds optimization leads, not just for hypertension, but also for, you know, CPCS or the contraception service that's coming, because we don't own that data as an LPC, and we don't always necessarily have access to it ourselves. But that is work in progress to ensure that that is. But that tool is already available to my knowledge, so I'll try and find the link for you.
Yeah, I think that was going to be really helpful, and that the Shape Atlas tool, I booked on for the webinar to understand how to use it. I think it's next week. I think the one thing I think with this service we've really got to be careful of is that by a pharmacist saying that they're doing it, we still don't understand maybe what the capacity is that they've got. Could they do 10 a week, 5 a week, 100 a week? We don't know what that is. You know, like you know, at the moment it is just a pharmacist-led service, so that is going to really limit the numbers that a pharmacist can manage and amongst all of their other work. We know we've got technicians ability to do it hopefully later this year or by the end of this year, and that will free up some more capacity in pharmacy potentially to do some more. But we also know that not every pharmacy has a registered tech, so it will be different, I think, around the different pharmacies. But certainly we'll speak about what we can do. We'll find out what we can do and share what we can. There it is. Love just got it in the chat already.
I just thought I'd share that while we're.
Sorry, can I just come back with a couple of other questions, if I may?
Yeah, of course you can. Yeah.
One around sort of equipment validation. I know you said to go back to the manufacturers, but we're using sort of a just off the shelf sort of Omron blood pressure machine that we've traditionally sold to patients. Now, normally we haven't had to get these validated or look into validation. Is there some sort of a standard as to, you know, what we should be aiming for with the equipment in terms of validation sort of timeframes and how validation is done and whether you need certification? Because they're not really that expensive, even if you have to sort of change them every, well, I don't know, whatever number of months or years.
I'll be honest with you. When we looked into, I was involved with the pilot in Cheshire and Mersey, one of the pilots for this. And we weren't doing ABPM there. We were just doing blood pressures and follow-ups after 2 weeks. And our blood pressure monitors were provided to pharmacy for free from the British Heart Foundation. But when it came to recalibrating, it was actually more expensive to have them recalibrated and checked than it was to buy a new one. And that probably won't apply to our ABPMs, which are considerably more expensive, but it may well apply to your blood pressure monitors, depending on which ones that you're using. Just make sure that any monitor that you do use is one of the approved ones, and there is a link on the PSNC website to the approved list of monitors that you can use. So there's a huge range on there, so I'm sure, and Omron are definitely on it, but it's different models. So do make sure you have a look at that and check. And there should be somewhere in the information regarding how often it should be recalibrated. But obviously we've not read every one because it would take us forever. But have a look at the information that's supplied with the product and just see what it says. But I know that the ones that we use for British Heart Foundation was every 2 years, but others may be different, and that's the problem we've got. And I think when I mentioned it for the SOP, it's just a case of checking your own equipment and seeing what it says.
And for the ABPMs, is it similar?
Again, it'll be the same. It'll just be check the manufacturer's information that's there as to what they recommend, and how to do it. I'm sure, I would hope at the price of paying for the ABPMs that it's in there, but I've not actually had a look myself to see, so have a look at the information.
Okay, thank you for that. And something sort of completely different point altogether. In terms of sort of eligibility criteria for this, I think there is I've read somewhere that pharmacists can use their discretion for certain patients based on sort of age and, other things. I don't think it's a monitoring service as such, is it? However, there may be some patients that you think, maybe looking at their medication sort of compliance, or those sort of factors that you think, oh, they may benefit from having a check. Or you might think, well, they're not the type that are going to go and see the doctor. You keep seeing the notes on the repeats that say book your annual review, blah blah blah. Do we have some discretion to sort of include those people if we feel that that's warranted or needed? How strict?
I think what I would do in that situation is, if it's a patient who's already hypertensive, technically they are excluded from the case finding, obviously, but they would be eligible if a GP referred them. It may be worth having a word with the GP practice and say, would you like us to do this patient for you? And if they say yes, that's your permission, you can do it. That's how I would do it. Or ask them to change the note that they put on the prescription. So rather than saying, please ask a patient to come in for BP check, they could write on the prescription, please complete BP check and send results back to us. Dear pharmacist, pop it in the notes section. I think you do need that referral, but there are ways to, it's really loose, the spec, as to how those referrals land with you. And although we're encouraging PharmOutcomes all the way and to get that audit trail, and so we can see the numbers of referrals coming in from general practice, if you've got a patient like that where you think it's going to be a benefit to that patient, that BP check is more important than making sure it comes through PharmOutcomes. So just pick up the phone to the practice. That's what I would do. Would you agree, Lovejoy?
I totally agree with you. My other point is there was another part of your question which was around, for example, slight. So, for example, if you had a patient who had a family history of some, of cardiovascular disease, but they're not undiagnosed, but say, for example, they're aged 35 to 39. I think that, for example, Lou, in accordance to the spec, is a reasonable person for you to treat. I think we should steer away, as Lou said, from anybody that's already a diagnosed hypertensive, because that's outside of the criteria. But if somebody hasn't been diagnosed with hypertension, but there are risk factors that you see and they're kind of roughly in that age group, then I think that pharmacist discretion, is perfectly reasonable to in that instance to provide a clinic check. Yes. But I completely agree with Lou's point that if it's already diagnosed, then just pick up the phone to the practice and say, this person's come here, could we just use this opportunity to, and you can sell it as, we're going to make every contact count and provide them further advice on, diet, lifestyle. You might provide stop smoking services, so that encompasses all of, the healthy living pharmacy elements as well as the stop smoking.
Yeah, no, I understand that. I think the only slight concern I would have is, obviously, is how much time and getting through to the right people there and then, and before you know it, the patient's like lost interest and gone because you've got to capture them whilst they're in the pharmacy. So it's just that kind of thing. But I guess I do follow what you're saying. So long as we have a little bit of sort of discretion, I think maybe it's a case of sort of agreeing some rules with the local GPs as to what they're sort of comfortable with you doing, perhaps.
Yeah.
And
Yeah.
you know,
That's absolutely it. And it may be that you can have a conversation around, you know, if I've got a patient that I'm concerned about where you've repeatedly put a message on about having a blood pressure check, can I do those? And the GP says to you, yes, please do all of those patients. Or have a conversation with them about getting their blood pressure checked.
Yeah.
And that is that GP given permission for you to do those patients. But it needs to be almost that permission's been given to you either for an individual patient or for a small cohort of patients that you've got concerns about. But it is where you have to have that conversation. And I would maybe try and get that confirmed in an email by the practice. So even if it's further to our conversation, dear doctor, and we've agreed that we'll capture these small number of patients because of X, Y, and Z, and they come back to you and say, yes, that's fine, thanks very much. Just something that just documents it a little bit for yourself, and just in case there's any checks later down the line, that we don't want to get into any sticky situations.
And I think that's why they've left the specification quite loose, haven't they? Because they've said that general practice could agree a list of patients and send them over to you. Or they might even say, well, actually, if you see a patient that's within this criteria and has already, you know, but it's from our practice, we would be more than happy for you to do it. I think that's the reason why that flexibility and looseness, if you like, in the spec is there to allow that local need to be met in accordance to what the general practice and pharmacy think local patients need. So in some ways, I'm quite relieved, Lou, that isn't as constrained, because it gives a lot of flexibility to general practice and pharmacy to be able to support an improvement in cardiovascular outcomes, but it must be by agreement and documented. That's what I would say is really key, so that there's no dispute later.
Yeah.
Thank you.
Have we got any more questions from anybody? I've not checked the chat for a while. Let me have a look. Is there anything in there?
I've got a hand up from Zoe, I think.
Hi, I've found out how to get my hand up now. I couldn't before. I just wanted to check with regards to the information being sent back to the GPs. Is it going in with potentially a list of patients and their blood pressures on one piece of paper, or is it going back through PharmOutcomes as one patient with their results? Because when we had our local event recently, some of the feedback coming from the GPs was it's really helpful if we get the individual result back for that patient. We can scan it and it goes straight into the notes, where obviously if you get a list with 10 patients on with 10 results, that's a lot more cumbersome and timely to have to then pull it all apart and put it into the notes. I just wondered if you knew how it was going back in.
It can be either way, Zoe, and I think that's part of the problem. And maybe we may need to pick up and do a little bit more, some more comms with pharmacies on that. The spec does include the requirement to summarise and send a listing each week to general practice of the results. But what it doesn't account for is the fact that some local teams, we've been really fortunate up in the Northwest, have agreed to procure PharmOutcomes for us. So there's no need to do that piece of work. There's no need to do that summary, because if you put it onto PharmOutcomes, you've got your audit trail, you've got your recording, and you've got your notification to general practice. So I know we've had a couple of people who've mentioned that they've got some problems, and I'll have a look at those practices tomorrow and see where the problems might be. But we will encourage all pharmacies to use PharmOutcomes, because that is definitely, it's the most secure way. It's not going to get lost in a pile of paper on a reception desk or missed. You know, it gets straight there into the general practice, and that's what wants to happen. I do know though that for non-EMIS practices, the pharmacists can still use the standalone template for any referrals or any BP checks that they do, but they're probably not going to be as aware of it maybe as those that are getting the referrals in via EMIS. So I think probably just need to do a bit more comms, Lovejet, this week on that, and get it out into our newsletters maybe.
Yeah, and that would be really helpful, because I think linked to that is similar to where we're obviously some of the issues that have been raised around CPCS referrals going in via NHS mail, and that sometimes they're not being picked up in a timely manner with the capacity issues that are obviously happening in pharmacy at the moment. I'm just wondering, is there some comms going out where we're now actually recommending for non-EMIS practices that referrals go in via NHS mail? Is there sort of some work being done to make sure that those referrals are then being picked up at the pharmacy? I know there's probably the time element's not maybe is essential with the CPCS, where it's expected to be picked up within a particular time frame. But I'm just thinking around some of the messaging that we've got similar services with referrals coming from GP to community pharmacy, with lots of different recommendations, really, because obviously we haven't got the PharmRefer option available for the hypertension service at the moment. We're sort of plugging that for the non-EMIS practices for CPCS and trying not to do the NHS mail, but then we're now telling practices, if you haven't got EMIS, you've got to do it by NHS mail. So I'm just thinking around some of those comms to, do you understand what I'm saying? Just so that there's not that confusion, well, we're doing it this way for this one, but this way for another service.
I must say, Zoe, it's not ideal that PharmRefer isn't commissioned at the moment, and I do believe that it's in progress, and if that option comes along, we will use it. There is genuinely no other IT option. The second difference, I suppose, with the hypertension case finding service is that's why we ask community pharmacy to approach general practice first with the toolkit and agree what capacity is there, and it's also up to general practice to see if they want to engage. It's not GP-CPCS is a bit different because it's been set up and the referrals just go anyway regardless, but this is going to require an upfront conversation, so we wouldn't expect general practice to be sending referrals to community pharmacy without prior agreement between them. And so if they've actually agreed it, yes, I'm going to be receiving 10 patients or 20 patients, or we're happy to pick up anybody that is hypertensive but hasn't had, that's the reason why this is the other way around this time, because we needed to account for the fact that there are pressures. It might be that general practice aren't actually ready at this moment in time and will need more time. But if for any reason community pharmacy approach them and pharmacy do have capacity, only then should they be going to speak to the local general practice about it. Otherwise, we're saying don't go and speak to anybody if you don't have capacity. So we wouldn't expect, would we, Lou, any referrals to be sent unless prior agreement's been made between the general practice and community pharmacy concerned to alleviate that particular pressure.
Yeah.
So is the expectation that the community, say we have a community pharmacy that has capacity and approaches a GP practice, but there's more than one GP practice within the PCN wanting to obviously send referrals out? I'm just thinking from our perspective, how do we support that? Because we don't obviously want 4 GP practices referring into one pharmacy and then all of a sudden they haven't got capacity. Is that being managed within PCNs to sort of to ensure there's more than one pharmacy, or how's that sort of conversation taking place?
I do have experience of this, but not in Greater Manchester, Zoe, where it did go a little bit wrong because a practice thought this is a wonderful idea. They didn't have any conversation with the pharmacies, but they sent 450 referrals to 3 pharmacies. And the pharmacies were they were trying the best, bless them, but they were really overwhelmed. So we have gone in now and had a bit of a chat with the PCN there around how to manage it and ensuring the conversations happen. They've been told to do that. It hadn't happened, so I suspect it will happen again, and some practices will just think this is great, can't wait, and they will start to send referrals across. So I think we haven't got access to the data at the moment, unfortunately, so we can't see what's going on out there. So we can't have a look and say, oh gosh, this practice in Wigan sending hundreds of referrals, and we need to check the pharmacies are okay and that they're managing it. We haven't got that ability yet. Hopefully we've asked for access to the data and hopefully it'll be granted to us, but at the moment we don't. So we are relying on local intelligence. We're relying on pharmacies out there to come to us and say, make it stop. How do I make it stop? What do I need to do? Will I catch up? Because the pharmacies want to do it, the ones that I've spoken to, but it is just getting that capacity right. And like you say, if you've got one pharmacy who can do it, but you've got 3 practices, if the pharmacy says I can do 10 a week and everybody sends 10 a week, it's 3 times more than they can cope with. And I haven't got an answer to that because I can't rationalise it in my head, which is why I think those local conversations are just so important, and just building those.
Also, the nominated the patient where they are nominated is quite important here, isn't it, Lou? I mean, ideally, you wouldn't be sending, somebody to another pharmacy to get done when their nominated pharmacy is another one, and that in itself is, for me, is a bit of a control, because that nomination process is almost manage the workload in itself. So we would encourage that wherever a patient has nominated their pharmacy, that's the pharmacy where their hypertension case finding would take place in an ideal situation. That's not to say that if somebody walked into the service, they couldn't have it anywhere they wanted. They could, but if it's a referral, I think you'll find that that will pretty much alleviate any risk associated with anything going to one, because why would you send a patient that's nominated to pharmacy X to pharmacy Y to have their hypertension case finding? It doesn't make sense in terms of the patient journey, and you know, the fact that they're getting their services or repeat prescriptions, and that also acts as a protection for the patient to ensure they're getting the service from the pharmacy they've chosen to get it from.
Yeah, and I suppose the difficulty is if you've got a pharmacy that has advised they have got capacity to maybe more than one practice within there. If you've got more than one local practice and that practice is chomping at the bit to go live, then they are probably going to send it the referral through to that pharmacy, aren't they? Even if it's not their nominated pharmacy. So I suppose from our perspective, if we're being approached, should we be basically saying, if they haven't been approached, if the practices haven't been contacted by the pharmacy, then we've got to assume that that pharmacy is not able to accept referrals, or that the practice actively approaches that pharmacy and checks whether they've got any capacity.
I don't think there's any harm in practices speaking to pharmacies and asking the question.
Yeah.
I don't, you know, we've certainly encouraged practices to speak to pharmacies, and you know, I think that two-way conversation is really important, and I think pharmacies would welcome that. I don't know if anybody on the call wants to comment, but I think it does make them feel a bit more a part of it. We're not trying to sell something that the GPs want it. That's great, but it is getting that number right, and every pharmacy will be different. But I think if you can open that communication channel, it's a start, isn't it? And you know, building those relationships is really, really important, and to everything we're going to do in the future. And hopefully we will have very few problems. But like I say, you know, I had a problem in another area that I work, but it was the only one. Every other one practicing pharmacy just got along and got on with it, and that's been great. But we're just going to have to try and monitor it as best we can, aren't we, Lovejet? But we are relying on the pharmacies. So all of you on the call today, you know, just to let us know how it's going, if you've had any problems, any challenges. We won't be directly contacting people at the moment because, like I say, we don't have the data. So it would be it wouldn't bring much benefit to be phoning and speaking to pharmacies. But if you've got things to tell us, even if you think it's something quite small, pick up the phone, send us an email, and you know, we'll happily have a look at it and see what we can do to help. Just simple things like, you know, like a couple of people have raised today around the notifications not going. Probably quite a quick fix to that, but we don't know it's broken unless somebody tells us.
Yeah, and the other point I just wanted to add was that the reason why we presented to community pharmacy in this way is that we didn't want to add any more burden to general practice, because that's been quite a lengthy part of the discussions at GM level, for example, with the LMCs or with the GP board, and they were very, very worried about them having to actually take the workload on to establish the relationship. Now, that's not to say, Zoe, that, you know, if a practice wants to get in touch with a pharmacy and ask them about it, we are more than happy for that to happen. But we've arranged it this way to ensure that we mitigate any concerns that were raised by our GP colleagues of additional work that's being put onto them, especially in the context of all the announcements and updates that we have. But anybody is free to speak to each other, and if in Wigan, for example, you're able to facilitate that, you know, I'm sure that community pharmacy would be more than welcoming of that. This is arranged that way just more to take the pressure off and not expect that it's general practice's responsibility to kind of open that conversation up. Oh, there's a question in the chat, Lloyd. I'll probably ask you, how long after can you carry out a BP check again on the same patient?
I think it's every 12 months, isn't it? I think if it's a referral from a GP, it's whenever they ask you to do it. So maybe that they want one doing sooner. If it's a clinic check for a patient that's not had that's not got hypertension, you can redo it after 12 months. Brilliant.
And I just had one final point to make with regards to Zoe's point, but I think it's gone out of my head like it does, because there's so many things to consider. But I'll come back if you know, if I remember what the point is. I mean, I remembered what it is. I'm so sorry. It's just that this service was commissioned last November, wasn't it, Lou? and actually quite a lot of information's already been sent to general practice, and over 100,000 clinic checks have been completed by community pharmacy nationally as of April 2022. I think good news is we've never heard any negativity or any, feedback from practices saying this is not appropriate, who's doing it, why is it doing it. So this should really just be consolidating and building on something that's already been happening since last November. So yeah. I think it's been a year actually. Oh my goodness, yeah. So
yeah. What we do know is that the Northwest is streets ahead of the rest of the country. We're doing a fantastic job up here, so we should all be really proud of what we've done, what we've achieved so far, because we are doing a fantastic job with the service. But now, obviously, the GP element, now that part is sorted, is the next part to add into it. Have we got any more questions? Anybody want to ask anything at all?
Sorry, just one that's just come to me just now. From the point of GP referral, is this some sort of a standard time frame by which you must action that referral? A little bit like the CPCS, where you need to contact the patient, that same day, or just talking about sort of some of the pressures that may come community pharmacy's way if these referrals go sort of really, really well, and managing that workload.
There isn't a time frame as such. So if a GP was to refer for ABPM, for example, which some GPs might, there may be a bit more of an urgency around that because they've already suspect that patient's got hypertension and they want to confirm it. So that might be a bit more urgent. A lot of the blood pressure checks that GPs are going to be asking you to are going to be routine checks. So again, that's where that conversation is really important. So it could well be that, can you please do checks on this patient for their HRT, for their contraception, for whatever it is, the next time they collect their prescription from you.
Right.
So again, so I wouldn't say that it urges. I think if you hadn't made any arrangements and a referral came through, I'd say as long as you're doing it in a couple of weeks, that'd be fine. But it may well be that I had one pharmacy that I contacted who got quite a backlog of referrals, and I was a bit worried about them, and they just said no, it's absolutely fine. The GP's just said to do them when they come in to pick up the scripts, but we get mainly 56-day scripts where we are, so some of the referrals are outstanding for nearly 2 months, and the GP was quite happy with that, and they just wanted the results in before the patient needed their following issue, if that makes sense. So again, that's why speaking to the practice and just working out a process between you, how you're going to deal with different cohorts of patients, timelines, timeframes, that kind of thing is important. But yeah, it's not like CPCS. We wouldn't be, if we had access to the data, we wouldn't be contacting you on a Monday to say you'd not done one from the Friday, put it that way.
Yeah. And that agreement with general practice is really key. I think managing the expectation is really important. That's very dependent on the local conversation, so if you've got capacity issues and you've got a series of referrals that you need completing, you can phone the practice and say, is it okay for us to be able to do this in the next month, or is it, is it more urgent? And that's where that integrated working and that local conversation is really, really key.
Yeah, I do think it's, things like, if you're going to be on annual leave for a couple of weeks, maybe, and letting your practice know. I mean, they can continue to send referrals through if they want to, but you'll pick up when you get back. But if you've got locums or relief pharmacists and you maybe aren't going to be able to deliver the service while you're away, just letting the practice know there might be a little bit of a delay on your return, things like that's going to be, again, what we really hoping this is going to really do is really integrate community and pharmacy and GPs working together much more closely. It's another step, isn't it? We started with GP PCS, we've got this service on now, we do a little bit of it with DMS. It's all around building those relationships and working together better. And hopefully there'll be more to come in the future. And I've got contraception around the corner and other things.
And I presume, sort of just looking at that, it may be worth just checking whether PharmOutcomes has some sort of a mechanism of capturing any DNAs or people that maybe haven't responded to you contacting them and coming in, etc., within a certain time frame. So that information is then fed back to the GP. I don't know whether that's
if you reject a patient from the hypertension service on PharmOutcomes, been referred via PharmOutcomes, a message does go back to the GP to say they've been rejected. So, like I said before, it could be that you've rejected them because it was the wrong referral. It should have been a GP PCS. I have seen some of that happening. It may be that the patient has decided they want their blood pressure checking in general practice. And they've had the odd one that I've seen that's been housebound and they can't get out. And obviously we're not going to be going out and doing it domiciliary. So if you do send that message back, you do reject it, the message will go back to the GP practice to say that's happened. What doesn't happen is if you're waiting for a patient, so for example, you've got an appointment booked in with them in 2 weeks, that message won't go back to the GP. So I think it's that little bit, isn't it? It's almost like we want an interim message to go back sometimes, and that just isn't possible. But you could always send an email, I suppose, if you've got that facility to do that with your GPs. Have we got any other questions from anybody? There's nothing in chat, I don't think. Almost spot on time for 8 o'clock finish, love Jet.
Fantastic, yeah, and thank you so much everybody for attending tonight. We will make a copy of the recorded webinar available, and we will share the slides, won't we, Lou, afterwards.
Yeah.
If you have any other questions for us, we'll put our contact details in the chat, but I'm sure you know who we are now and you can get in touch with us anytime. And I put some things in the chat with regards to the PSNC information, the GM arrangements and the toolkit that we spoke about as well. So all those resources available for you there as well. So thank you very much, and have a wonderful evening. And thank you so much for all your hard work today as well. We're very grateful. Thank you. Bye.
Thank you very much. Thanks.